Going now to Rushanara, please.
Hi there. Good afternoon. Thank you very much. That's fascinating so far. I'm going to focus my questions on the estimated number of lives saved, and starting with Professor Miles and Professor Foster. Professor Foster, you mentioned the 1.5 million COVID deaths that was being estimated. The UK government's own analysis indicates that mitigation, including social restrictions, has prevented that 1.5 million number of deaths when you take into account deaths due to lack of NHS critical capacity. Would many of the 1.5 million deaths have been prevented anyway without a stringent lockdown due to greater hand washing and people avoiding social contact? Because you seem to be suggesting that that number is not reliable.
Well, I certainly do think that it's that 1.5 million deaths is totally unrealistic based on the observed death rates in any country in the world that we've seen so far. And therefore, it's very clear that the UK is killing many more people via lockdowns and suspended health services than it could possibly save from COVID. And indeed, if it really wanted to save people from COVID,
the UK government analysis this is not my analysis. The UK's own government analysis is saying that that's the number of those, that the 1.5 million COVID deaths have been prevented. So you dispute that?
Absolutely, I do. Again,
right.
Look and take any country in the world.
Can I just probe you just for a minute? Your points are made in relation to not having restrictions. The UK government is arguing that because of they prevented this, the analysis shows they prevented this by having the restrictions.
Well, again, the key fallacy underlying your question and your line of questioning is the presumption of government agency. That is that governments can choose to keep death rates low by having lockdowns, and rather than that death rates are actually largely a function of other factors. And in fact, they seem to be largely a function of other factors. For example, look at Peru, very, very strong lockdowns, and yet almost the highest death count in the world. So underlying agency for COVID death rates actually less with government lockdown policies and more with other sorts of factors like pre-existing immunity, T-cell resistance, the underlying health of the population, etc. And indeed, it's possible that those kinds of resistance levels were higher in East Asia, which is maybe why they hadn't lost as many people. So I think it's more...
But are we not talking about lots of different variables here? You know, in certain countries, you've got a younger population. In Europe, you've got an aging population. So I'm not disagreeing with you about some of the points around demographics, for instance, but you're moving between countries and examples. Just focusing back on the UK, so you're saying that this could have, actually it had nothing to do with lockdown, this prevention number.
It had nothing to do with them, but again, take any country in the world. I mean, we can't simply make these numbers up based on models that don't get updated when we observe real human behavior. Every country in the world, no matter the lockdown policy, no matter how stringent or relaxed it was, none of these countries in the world has lost more than 0.1, I think Peru is up to maybe 0.12 or something % of their populations. So 1.5 million British citizens is just way above that, right? What we're talking about for Britain would be maybe 80,000, 86,000 at the upper level. So I just think it's way off. Yeah.
Interesting. Thank you very much, Professor Miles. Can you reflect on?
Yes.
On this?
Well, I recall very well, and I expect you do as well, the very influential study produced by my colleagues at Imperial in the epidemiology department, not us economists. And there was a calculation there that but it was very careful, the caveat. What it said was that if there were no behavioural changes at all in the UK, that perhaps 500,000 people might die. But it was recognised in the paper that it was extremely implausible that even if the government did nothing, there would be no behavioural changes. I mean, you could imagine that if deaths were rising so strongly, people would do all kinds of things. And therefore, they didn't in any way suggest that the restrictive policies that we've seen in the UK have saved anything like 500,000, because there was a recognition that there would be these natural responses from people. I think the interesting question is, well, let's suppose the government response had been short of the total lockdown almost total lockdown we had in the UK, but had been more along the lines of, this is very serious, you should do this, you should do that, you must wear a mask, short of that. I think the interesting question is, well, how many more deaths might we have had if instead of a 3-month, almost complete lockdown, there was a short, sharp lockdown, but strong advice that people should take care? And I think it's very difficult to be sure on that question.
Right.
That's why in the study that I undertook, I had very different scenarios which involved high estimates and low estimates of the extra lives you save as a result of a lockdown. And it still didn't look sensible to have a 3-month lockdown.
Yeah. So just picking up on that point, can you just say a bit more about the issues relating to NHS critical care capacity? Obviously, at the time of the lockdown, there was a heavy focus on protecting the NHS and the lockdown restrictions being motivated in part by that. Could you elaborate on that and how that motivation impacted?
Yes, I mean, my recollection, and you'll correct me if I'm wrong on this, was that the very precarious situation in intensive care was very severe in the middle and toward the end of March and early April, but that situation was much less worrisome by a few weeks into April, both as capacity came on stream and as the numbers of new infected people did begin to decline very sharply. So once again, I wouldn't want to argue that there's overwhelming evidence that the short, sharp lockdown was a catastrophic policy. I don't take that position. It is that we kept restrictions in place for longer than was necessary and plausibly offsetting the ever-rising costs of doing it.
Tony Yates, you put your hand up.
Yeah, so I just want to pull back a bit to what I think is still the big picture as it was at the time those that Ferguson and the others from Imperial did their work, which was that the chance of dying from this, if you catch it, is something in the region of 0.6 to 1%, and that is if you get good care. Things have improved somewhat, we think, since then through better knowledge and 1 or 2 treatments. Whether there is voluntary social distancing or enforced social distancing, eventually 60% of people, roughly, the herd immunity point, so-called, are going to catch it. So the amount of people that will die from it is the infection fatality rate applied to 60% of the population. So that is what the current policy strategy is trying to avoid. One tries to suppress the virus, transit hopefully to suppressing with test and trace, and we wait with hope for future treatments and maybe a vaccine. The alternative is letting, roughly 1%, that's slightly an overestimate, slightly, of 60% of people die, plus all of the other health costs from people who get long COVID. There is nothing that we have learned since then to change that big picture very radically.
Mm-hmm. Thank you. So we are now heading in the UK into a second wave, and obviously you can see we're all following the debates and discussions about localized lockdowns or the various tiers. Can each of you talk us through what, from your perspective, and I obviously different perspectives, the government should be doing now? What are the key lessons that need to be learned from what's gone on before? In terms of what we do going forward? Who would like to come in first? Professor Miles.
If I may briefly. I think the crucial thing is to really come back to this formidably difficult question about trade-offs. It's very clear that you could bring the infection rate down in the UK, and you could have an impact on the number of deaths that we face between now and Christmas with a return to a very strict lockdown and keep it in place for 3 months. It's also very clear that the economic and health damage of that would be absolutely enormous. But I think you can't get around this question, whichever way you try, of trying to evaluate, assess in some way the trade-offs. It may be that a short, sharp lockdown for a week or 2, will not cause enormous negative knock-on effects, but maybe it won't save all that many lives either, because once you relax it, you'll just be back on the track that you would. And I think it's that trade-off that you simply can't avoid trying to assess. And if I may say very briefly, one of the things I find slightly puzzling, it's not a criticism, but slightly puzzling about some of the very clear policy recommendations that come out of SAGE, is that on the one hand, although they seem to recognize this trade-off, they also give advice which actually ignores the trade-off. I was very struck by reading the SAGE advice of 21st of September, which was released very recently, which said that we need another lockdown in the UK. And if I may just read, it won't take more than 20 seconds, just read what they went on to say. The evidence base into the effectiveness and harm of these interventions is generally weak. Nevertheless, non-pharmaceutical interventions will need to be in place for a considerable period of time. It is important, therefore, that studies are undertaken to evaluate the risks in different settings and the impact of different policies. Suggested data analysis of studies include studies on the impact of harm of interventions. What I think is extraordinary in some ways about that is that it is advice that we should definitely follow a policy, but also admitting that we don't know what the side effects will be, and wouldn't it be a good idea if somebody else thought about them? In some ways, it's rather a strange position for medically minded people to reach. We think there's a very harmful side effects. We don't know what they are, but I'm pretty sure you should do this.
Professor Foster.
So I think that the main thing that's needed is a new government message. I think one of the big mistakes of the UK government and other governments around the world during this period has been to fan the fear of the virus rather than controlling the fear and dampening it and providing perspective for people. In Australia, for example, we've lost fewer than 1,000 people to COVID, and we normally lose about 300 to 400 per day from all causes. So that perspective has been totally lacking, and governments have just played into that fear. What they really should do now, I feel, is pivot to a more human-friendly message. And that human-friendly message could be underpinned by a recognition that what governments really should be striving for is to maximize the welfare of their populations as understood broadly, not simply in relation to COVID deaths and suffering. And so I think that could be done in the UK particularly well, since you guys are the inventors of, in fact, the WellBe, and have been using QALYs for a long time. And so I think instead of focusing so much on COVID, and instead even of focusing on just GDP, we should potentially craft a new political message, which is about having conquered the immediate effects of the virus, the immediate crisis moment, and moving forward in ways that are aimed to protect all of the people.
Isn't the point though that it's not either or, it's not trade-offs, it's actually we've got to act on those fronts simultaneously, and it's tough for any government to do that, trying to bring some compromise between the different perspectives. But I just think it's not entirely helpful, is it, when we've got constituents who, I mean, I've had the fourth highest age standardized death rate in my constituency during the height of COVID, so it's not something that's being imagined, but at the same time your point about excess deaths and so on, and the wider factors are well made and the economic harms, but we need to act across the board on all of those fronts. Tony, do you want to just make a quick intervention? I'm going to have to stop.
Thanks. I just wanted to say that I think one thing I wanted to add is that my concern about the way it's proceeded is that the epidemiological advice and the economic advice, and this strikes something of a common chord, I think, with what Professor Miles said, have proceeded in a siloed fashion. So in some senses, I say this slightly unfairly because it's a fashion in which the two things were fused together is something we're only doing now. So you've had SAGE forecasting the epidemic without taking account of economics, and you've got the Treasury doing things in private without taking account of the epidemic because they can't. They've got economists who don't know how to do this. And the same is true of the Office for Budget Responsibility, and the same is true of the Bank of England and dozens of other economic outfits. What one really would have liked to have had, and I think we should have, and that's partly why I came on, is you have an institutional device that brings researchers and policymakers, policy advisors rather, together to build a set of fused analytical tools, where one can study these things. I mean, I don't think there is a trade-off in the long run, but there'll certainly be difficult choices to make about you know, who bears the costs, and there are intertemporal trade-offs, and these things can be worked out and exposed and even depoliticized somewhat, so that there are a menu of things that are put on the table for MPs like yourself to actually make intelligent choices.
Thank you very much.